Thank you. Hi, everyone. Good afternoon. This is Dr. Dave. We are live from Thousand Oaks, California, Los Robles Hospital and Medical Center. And this is a very complex patient, a 65-year-old lady with multiple behavioral problems and was found about 12 days ago by her family on the ground, very short of breath, altered level of sensorium, and was brought to the emergency room, was found to have urinary tract infection and was initially treated for sepsis, but was very hypoxic. And evaluation with CT pulmonary angiography showed bilateral pulmonary embolism. She also had bilateral deep venous thrombosis. She was obviously started on full anticoagulation and oxygen support. Her hypotension responded to IV fluids, but her cardiac enzymes were elevated, and initial elevated troponin was attributed to pulmonary embolism because that can cause, obviously, high-risk pulmonary embolism would cause troponin elevations. Over the next few days, patient continued to not perform well and then became progressively tachycardiac, hypotensive, and tachypneic, required BiPAP support. And the cardiac enzymes went up further, and the troponin levels peaked at about 5,000. Also, her echocardiogram in the beginning was obtained, which showed the left ventricular function was normal and right ventricle was not dilated. So initial plan for doing a pulmonary thrombectomy was not considered appropriate, as the patient did not have enlarged dilated hypokinetic right ventricle, which would be an indication for taking her for pulmonary thrombectomy. However, a second echocardiogram done 5 days later showed her ejection fraction had been reduced to about 40%. That, along with elevated troponin, prompted us to bringing her to the cardiac catheterization lab after ruling out sepsis and numerous other things. Her level of sensorium has improved since then, and we brought her yesterday to the cardiac catheterization lab. And this live view of the angiogram that we see now was the left ventricular angiogram that was done at the end of the PCI procedure. And as you can tell, the ejection fraction is about 20%. The high lateral, very proximal anterior wall, that's the only thing that's contracting. All other segments seem to be hypo or akinetic. And this is what her coronary arteries look like. The left main was okay. Very extensive calcification in the left anterior descending artery. You can see most of the coronaries even before the contrast is injected. Subtotal occlusion in the mid segment of the LAD, but the distal left anterior descending artery has extensive atherosclerosis and is very small in caliber. As you can see, very proximal circumflex artery has a subtotal occlusion as well, which is like a short shelf-like lesion. And there is a distal obtuse marginal branch that has disease. And as you can tell, the right coronary artery has high-grade stenosis as well. The initial thought was to evaluate for cardiac surgery. The cardiac surgeon looked at the echocardiogram, the LV function, patient's bilateral pulmonary embolism, diabetes, psych problems, and persistent hypotension and tachycardia. And she was deemed to be a prohibitive risk for surgery. So I was charged with the responsibility of trying to revascularize this percutaneously. If you can go back to the very first picture, again, This obviously is a complex revascularization case, irrespective of what technology we use. The left anterior descending artery is not a good target for bypass. So even if miraculously somebody could drop a lima, that likely wouldn't survive. The distal obtuse marginal branch also appears to be too small. But more importantly, it's heavily calcified, and that would make PCI complex as well. And because of the LV function being so poor, a rotablator is not even an option. So we decided to proceed with PCI, and we thought if we can get the major segments of the left anterior descending artery and the very proximal circumflex subtotal occlusion fixed, and then put her on hemodynamic support and re-evaluate and see how things go. So with that plan, after conversation with all the physicians involved, we went ahead with the PCI. Next. Fortunately, we were able to wire the arteries well and easily. The left anterior descending artery after the guide wire, as you can tell, the flow has become even slower. It was tough to cross the blockage with any balloons. Fortunately, finally, we were able to get a sprinter across, and then sequential dilatation with 1.5 and 2.0, and then balloons. And then finally, we got our first stent. Next. And we had a wire in the left, in the circumflex artery as a support. Next. Next. So that's a long stent, 28 millimeters, and covers the entire disease segment, but the ostial left anterior descending artery still didn't look very happy. And the mid to distal left anterior descending artery has some mild dissection, but the flow was brisk. This stent was post-dilated at 22 atmospheric pressure, and then next we decided to go ahead and fix the proximal circumflex artery with a stent. Next. And that's another stent. I think it's a 3.0 by 16, covers the entire disease segment, and we stayed clear of the left main coronary artery there. Next. I did not like the ostium of the left anterior descending artery, and we decided to put a stent there and make sure we had no issue with reocclusion in this very sick patient. Next. So that's what is nearly the final result of the circumflex and the left anterior descending artery PCI. The proximal up to the mid segment of the LAD and the proximal circ, those lesions look great. There is distal part of the LAD, the flow is brisk, but there is a dissection. That vessel is too small, I thought, for putting in more stents. And that area was likely scar tissue, so we didn't want to waste more capital in terms of contrast, X-rays, and time. So we decided this would be a good time to take final pictures. We looked at the left ventricle that you saw before, and then went ahead with and put the patient on Impella left ventricular support. And next, last picture, yeah. So here is an Impella device in position, and we were able to get very good flow at P9, about 3.5 liters per minute. Patient remained hemodynamically stable and was transferred to the coronary care unit yesterday. Since yesterday, things have stabilized. We were able to get her off the levofed that she was on, and we decided to bring her back today to fix her right coronary artery. after evaluating the left coronary system. So this morning, we just now got access, and we have our catheter in place. Let's go move the. Let's see where the catheter is. Okay, actually, let's show the first picture that we already took of the left coronary system. So the proximal to mid, the stents look great. Brisk flow is noted. The left anterior descending artery has that dissection flap in the mid segment. I'm still thinking what we might do. I might, and the size looks slightly bigger than it appeared to me yesterday, so it could possibly take a 2.5 millimeter stent. So we might open it up if we have and put in a stent. The distal OM has a high-grade stenosis. It's a small vessel, but if we are going to go into the left system, we might fix that as well. But I think the first order of business, as per our original plan, is to fix the right coronary artery. Give me a guide wire and a dilator. A small guide wire. Okay. What's that? I think our sheath is not flushing well, so let's take it out. Let's exchange it. Give us a new 6 French sheath. Is she on Angiomax already? Yes. We just, bolus is going in? Okay. There is flow through the sheath, except that the valve usually gets, if you don't flush it, time. But we are going to exchange that for a new sheath anyway. And our cath lab team today, we have Colleen scrubbed with me. We have Kathy circulating, and Mike on the monitor. Gabe on the monitor now, and on in the cath lab and lovely Sophia just walked in. All right, so what we're going to do now is go with the right coronary guide catheter and see if we can get the right coronary artery vascularized. All right. All her coronaries are small in size, and the right coronary is also quite tortuous, and a long segment disease covering the proximal and the mid segment, just above the guide catheter right here. There it is. Okay. All right. I think the plan would be to cover the entire disease segment, and Seems like it's a 30 millimeter long segment approximately, if not 35. And the vessel size is beyond the lesion, it's about 2.5. The very proximal may be slightly bigger. And as you can see in that frozen frame, the lesion is subtotal. Here is our wire coming up. That's our workhorse balanced middleweight wire. Now it wants to go into the branch. Okay. Could you give me some contrast here, please? Yeah. Okay, so we are right at that subtotal occlusion. So we may need a hydrophilic wire to cross it. Could you give me a whisper wire, please? And we also may need a balloon to support its movement. Part of our perfect planning, we just ran out of the whisper wires. It may be a good idea to give me a 2O balloon, 2O20. Okay, that's enough. That's enough. Go ahead. Load the Okay, give me a puff here. Okay, I think we're very close to going past the lesion, but it'll need some guide balloon support. Not yet. Okay. Put some light here. retorker on the back. I was worried about wiring this lesion because it's so long and subtotal and on a tortuous vessel, but I think we're making some headway. We're past the worst lesion. Into the second branch. It will choose every branch on the way now. The third branch. Now the RCA main. These cases tend to be a game of patience more than anything else. All right, so at least verify that in the right spot. Okay, now let's see if with some luck we can cross with a balloon. We don't have a lot of backup support, but I think it wants to do it. Go all the way down first, and we'll come back. Easier to pull in an artery than to push. All right, 11, 12. Our guide catheter is a little deeper in. The pressure is damped, but I would rather let it be there for now. Okay. I think that covers the entire disease segment. Okay. And let's see what we get. How is the pressure? A little low. Okay, so we need to dilate that area, just proximal part. Okay, let's get the balloon back. Take a picture. All right. Distal segment could take some dilatation. Good thing is nothing bad's happened so far. We are in good shape. I'm going to get the balloon and dilate the distal part, and then we'll take see what stent we can get through it. About here. Hemodynamics are stable. EKG, heart rate, no EKG changes. Blood pressure 103/83 by the cuff. The guide catheter pressure is damped. Okay. So I think we need to go right up to that area where our last inflation was. And I think it's 2.5 vessel. Okay, let's see if we can get a stent to go there without giving us much grief. And then let's try a 2.5 by 38. The lesion is long. It likely is maybe 40 millimeters or even longer, but we'll try and see if we can cover with one stent. One stent may not want to go anywhere, but we'll try. Okay. How much oxygen is she on? 2 liters, 3 liters? 2 liters, and she's saturating 98% happily. Okay, that's good. No discomfort. Patient is stable. Just the way we hope such complex patient turn out to be. I think the Impella 4.0 has something to do with that. Here it's a question of just going slow. If you push a little faster, then it'll push out the entire system. Our guide catheter is way out in the aorta.
Keep your hand down.
And now I'm going to advance the whole guide catheter and see if the stent will nicely go forward with it. Okay. I think we may have found just the right length. We have maybe a millimeter, maybe a couple of millimeters more to go. And distally, I think we're in the right spot. One more final check, and then we'll drop this stent here happily. And
Your hand down.
I think it went a little too deep. Yeah, we can come back a little. Okay. Just a small little injection to see what we need to see. All right, we're taking it here. All right, that's about 14. Let's go to 16. Let's take a look at what we've done. I think it's going to look nice. At the edge of the balloon, it's just the shadow of the balloon. We'll just dilate that gently, and then once we take out the balloon, it'll look nice. So let's go to about, where did we go, 16?
Yeah, we rated for 18.
Let's go to 20. We don't have to.
20 for 15.
All right. When the guide catheter is out of the coronary ostium and not too deep, the pressures are decent there as well. Okay, that's our final inflation. For some reason, this stent company hasn't been able to figure out how to get the balloons easily out of stents. They get sticky. Okay, we're out. All right, let's give a little nitro. Maybe our pressure is still low, but we'll give maybe 100 mics of nitro and take the final pictures of the right coronary artery. If everything else looks stable,
100 of nitro.
we might see if that mid LED can be optimized. Okay. All right, here is the final picture. I think that looks very nice. So balloon and wire out. Pressures look excellent. Yvonne, you feel okay?
Yes.
No chest pain, you feel well?
Yeah, I'm fine.
Good. No short of, you're not short of breath? Okay, good. We are just about done. Show me the left coronary system again, one more time. I have mixed emotions about this. The question is, there is brisk flow, there is a cap, but lumen is open, and it's very heavily diseased vessel. And we would be going through stents. And the apex that's supplied by that area, the LV apex is actually quite infarcted. So I think it may be that we've achieved our goal of revascularizing this patient to the degree that is safe, and we should let's take a guide. Let's take a look at it and see if yeah.
Oh, this is from the other day.
What's her creatinine? Okay. Creatinine is normal. Guess it doesn't want to engage it. Okay, let's take a new BMW wire, see if it would give me a torquer, introducer right there. Trying the balanced middle weight, the BMW wire, and we'll see if we can cross into the LED past that area of dissection. Okay. We definitely went without catching a strut because we went with a loop. I think so far so good. I think we're in the getting all the branches here. There is a branch that goes straight down to the apex, just like that. That's the one. Do we have a 20 by 30 balloon? Do we have 20 by 20? Okay, let's take 2020. Yeah. We just do a low pressure inflation a little longer to see if we can tack up that dissection from yesterday. If we'll also know whether the balloon goes through the stents easily. If it just flies through it, then we may be lucky enough to get a 225 stent, and that should hopefully fix this. And then we would have done everything that we possibly, yeah. Okay, here it goes. Wow, it wants to do it. So that's 2520. So we'll just do a gentle inflation at 6 atmospheres. Okay. So if we could get, this is 20. Let's leave it on for maybe 30 seconds. The dissection cap is actually just beyond this balloon. Balancing it carefully.
Going up.
Okay. 3, 4. I hope we don't make it worse. That's the main thing. Let's stay on for a minute. All right. That's the length of the segment. Just got the guide in the left main to get a better look at the artery. Yeah, doesn't want to completely go away. Distal vessel is even smaller. Possible we are just going to keep chasing this.
Going up.
That's 3. Okay. Let's take a picture. I may have been into a slippery slope. Bothering me. Okay, let's take a 225 by, what do we have? Do we have a 38? So we covered that dissection and proximal to it. Leave the distal vessel looks nicer. If we cover the flap, I think we'll be happy. I don't think she's ever going to get a lima, so I don't mind covering that area, considering how things are. Yeah, this was 20 millimeter balloon?
It was.
Okay. Yeah, let's take it. I hope this crosses as well as the balloon did. Yeah, I think we may have reached the, I'm just worried about that dissection flap. As long as we cover that, the rest of it, we don't really need much, but, and even that may be more cosmetic and for my peace of mind than, because for all we know, this area is actually, okay, so that will go to about 12. And then I'll pull this balloon back a little, and then can go up a little higher. Go to 16. There may have been some time when this vessel was 2.5, but now it's, I think, about barely 2. That's, now the distal segment is going to look worse than what it actually is, because the main fear here is that if the edge of the stent cuts through the vessel, you could actually perf, and that's obviously never pleasant. But I think here, now all those septals are coming from a wide open artery, and the distal artery looks the way it was. I think we pushed our luck enough, and I think we're done. Let's call it a day. Okay. Hey, Yvonne, you feel okay? Okay, so we'll tell you what to do with your hands, sweetheart. Just put them by your side. Okay, we are actually quite done. All right. So this case, there are numerous questions, and some of them I don't know whether we answered them correctly, in the sense that when we brought her in with cardiogenic shock, there was a component of sepsis, a component of pulmonary embolism, and of course a subacute slow-moving train wreck kind of myocardial infarction. When we did the angiogram, we found all three vessels diseased. Did not find something that was truly a thrombus related. So no obvious culprit. In a cardiogenic shock, the standard teaching is that you fix the culprit vessel and not try to open and to do full revascularization. My feeling was that the circumflex that short segment lesion may have been the possible culprit. So I wanted to make sure that we opened that. The LAD was too severely diseased, and it didn't make any sense to not fix it. And then we hoped that bringing her back and fixing the right coronary artery covers all our bases. It provides her revascularization of all the reasonable segments and gives her the best chance of recovering her heart function and getting better. The Impella left ventricular assist has definitely helped because patient is hemodynamically stable. But even with Impella yesterday, she was requiring some Levofed, which we don't need that anymore. And her oxygenation has been much, much better. She does not require BiPAP. She's comfortable with 2 liters of oxygen, and she's lying flat without and saturating at 96%. So I think despite initial doubts about what is the most logical answer to this patient's very serious problems, I think what we have done has stabilized her. And we hope now to get her off the Impella in the next 24 hours. We'll keep it on for 24 hours. And reassess her lungs, reassess her cardiovascular function, repeat an echocardiogram, and then hopefully we can get her off this stuff and go on to secondary prevention and treating her severe left ventricular dysfunction. Good thing is we haven't, during all this process, didn't mess up anything, so which is always a blessing. So thank you very much, everybody. I hope this case is helpful, and this is a real-world case. We actually did not even plan to do it today. This just happened to fall in today, and today happened to be our live case, so we decided to go with it. Thank you. All right.